to go ahead and kick off here. I know some people are maybe still being let in, but given this is people are relatively experienced after yesterday, I'm confident they'd rather listen to the other John Gruber and than me giving logistics. But let me do that briefly. So thanks to everyone for a fantastic first day. I personally found it incredibly informative. I hope you did as well, and very consistent with the motivation for this conference that I think Ben laid out at the beginning of yesterday. But just to reiterate sort of at the high level, our goal is to stimulate thinking, particularly amongst economists often focused on the US and often focused on inside baseball, to use the US parlance of specific things, getting very deep about particular components of the US healthcare system. And often, in our view, are potentially not learning enough from the myriad other health systems and solutions that are obviously tackling very similar issues across the world. So at minimum, we hope we stimulated some thinking. At maximum, maybe some things where we have evidence today or motivating research agendas and policy discussions. And we're going to continue in that theme today, I hope. We've got a fantastic lineup. We're going to be talking about managed competition and then innovation, which is something that I think has come up a number of times in a lot of contexts of different systems. So we're going to cover those things. But before that, we'll have our keynote address from John Gruber. And before I get to that quick intro, let me just do a couple of housekeeping items. A reminder that questions for any of the panelists will be in the Q&A function, and then I will be curating them. Now John's keynote is a standalone, so it's slightly different. So I'll do that directly after he speaks. When we have the sessions with two talks, we'll do both speakers and then consolidate questions into one. And we have 2 breaks today. So, you can get your coffee if you need it. And that is a reminder that I thank everyone from around the world who may be well past coffee and into whatever other drink comes in the course of the day. So I appreciate everyone coming in across all these time zones. The other logistical note is that we have closed captioning is available. You have to opt into that at the bottom right of your screen, at least on a standard PC or laptop. My iPad seems to be automatically doing it. So it's available either way. And if there's any logistical issues, just do that in the chat and we'll get that sorted out. So without further ado, I want to turn it over to John Gruber from MIT, who arguably needs no introduction, certainly to the group we have here, but just to think about someone who combined rigorous economics with thinking about policy questions. You can think of no better person than that. And so we're really excited to have John speaking to us today. And I will turn it over to you, John. I know you're going to screen share in a moment. You have until 30 minutes past, and then I'll collect questions at that point, if that works for you. So without further ado, here, John Gruber.
Thank you, John, for the introduction, and thanks, John and Ben, for running it. I think of John and Ben as such a sort of team. It reminds me of what happened. So my father is an academic and may hold the world record for writing articles with the same person. He wrote an article with a guy named Elton, and they were known as Elton and Gruber. And so much so that one time I went for a job interview and someone heard of my father and I said, "Oh, that's your father, Elton Gruber." And so someday, someone will say, "Oh, that was your father, Handel Kolstad," and we'll have that story to tell our children. Anyway, thanks so much for including me, and it's great to be here. And I'm just going to do a little presentation. So let me screen share here and go from there. Okay, got that, and here we go. Okay, so what I want to talk about is what's going on with healthcare reform in the U.S., what are the ongoing issues in international lessons. So actually a distressingly high ratio of politics to economics in this talk, but I'll try to sneak in a little economics as well. Let's remind ourselves of what U.S. healthcare looked like before the ACA. Before the ACA, we had about 60% of individuals were insured through employers with a large tax subsidy. About 20% were insured through the government. About 20% were uninsured. Now, uninsured could come in 2 forms. You could either be uninsured, literally you had no insurance. You could be effectively uninsured, which you could be subject to the discriminatory non-group insurance market. We had a market which is sort of bizarre from the perspective of the rest of the world, where insurers could literally deny you insurance or charge you multiple high prices based on your underlying health status. This makes no sense. It's not real insurance if you can only get it when you're healthy and can't get it when you're sick. But unfortunately, we found that we couldn't ban this in a vacuum. Indeed, a number of states in the 1990s tried banning insurer discrimination, imposing widespread community rating. And in every single state, the same thing happened. Insurers said, well, wait, I can't charge the sick more than the healthy, but people get to wait until they're sick to buy health insurance. I'm going to lose money. I'm out of here. So the insurance markets collapsed in every single state that tried this. The ACA was an attempt to try to address this through what I like to call the three-legged stool model. Okay, the first was to ban discrimination, as well as sort of sham insurance products or non-insurance. Ban products that, for example, had annual limits that were described on page 73 of the brochure that said, oh, by the way, once you spend more than $10,000, you're not covered, etc. The second piece was to have the individual mandate, a requirement that individuals buy health insurance. And the third piece was to expand the affordability of insurance through both, for the first time in our nation's history, having a true universal entitlement to free health insurance for the poor through the Medicaid expansions, and then offering tax credits for the near poor through the ACA exchanges. Now, in the spirit of the new movie that's out today, we'll say this is a great success, at least on policy grounds. There was about 20 million people were covered, and both the premiums and costs of this program are well below projections. So on policy grounds, it's a great success, but it was not a great success on political grounds. It was quite frankly, an outstanding failure. Now, part of the reason why, as I've had a decade to reflect on this, I think a big part of the reason why was because there was a very long delay between the passage of the law and the law actually delivering benefits. The law was passed 4 years before the benefits really started to flow. That meant 4 years of opponents attacking the law with really no basis, no substance. But there was no substance to point to on the other side. And, Mark Twain is just saying, a lie will get halfway around the world before the truth gets its boots on. And this was a 4-year lead for the lie over the truth. And so basically, by the time the law was implemented, people really had a pretty negative view of it. Add on the fact that the initial implementation went quite badly with a number of technical failures. Those technical failures were fixed within about 2 months, but the narrative was sort of set. And as a result, you had a situation where basically you had, as of January 2017, a president and Republican Congress which had campaigned on repealing and replacing the ACA. And things looked pretty dire for the law. But it turned out that repeal and replace was just repeal and repeal. There was no replace. There was no plan. Opponents of the ACA really had no plan to replace it. Plus, they want to do more than repeal ACA. They also want to cut the Medicaid program by about 25%. So they really sort of significantly overreached. Indeed, while the ACA covered 20 million people, the ACA repeal was projected to lead to uninsurance of about 32 million people. So actually, it was not just repealing the ACA, it was actually another 50% increase in the number of uninsured above that, because they wanted to go beyond repealing the ACA. So when it turned out that around this time, the ACA went from being unpopular to popular. I think people had really started to realize what they were getting from the program. And they realized that 32 million people losing insurance wasn't a great alternative. So the repeal efforts failed, although very narrowly failed. But efforts by the president and Congress significantly weakened the law. The individual mandate was taken away. Now, interestingly, there's a lot of revisionism going on in the individual mandate. Maybe it wasn't as important as we thought. The individual mandate's gone away. Premiums have gone up a lot, which is what you'd expect. But it turns out that the number of people covered hasn't gone down a whole lot, because it turns out that basically, sort of ironically, what Trump and the Republicans have done is turn the ACA from what it was designed to be, which is sort of a bipartisan law, to really a democratic law. Right now, basically, the people who have health insurance, the people who can get it for free or subsidized. Everyone doesn't get it for free or get it heavily subsidized, just doesn't buy, because with the mandate gone, the premiums have gone through the roof. I was just talking to my sister, who was considering whether buy her very ungenerous employer insurance or go on the exchange. And the exchange was still not even competitive with her ungenerous employer insurance, because basically without the mandate, only the sick are enrolling, and the sicker people enrolling and premiums are up. So what's happened is, in fact, in the number of uninsured covered by the law has fallen by about 3 million people, but the law hasn't collapsed. It's still quite robust. But there are more sort of escape valves from the regulated insurance market. There's more and more plans that are being put in regulatorily that are not legitimate insurance, so-called short-term insurance plans or Christian healing insurance plans, which are plans which aren't real insurance, but which are evading the regulations put in by the ACA to try to create a robust universal insurance. And in addition, the Medicaid expansions remain partial. 13 states, including the big ones of Texas and Florida, have, for no other reason than pure political spite, not expand their Medicaid program. Just to remind you, the way the Medicaid expansions work is the federal government said, if you will agree to cover your poorest citizens, the federal government will pick up 90% of the cost. There is no macro model out there that doesn't say a 90% match from the federal government doesn't pay for itself through fiscal multipliers. So this is a good deal for states. This is really, from a given state's perspective, this was as close you get to Pareto improvement. You get basically more than 100% once you factor in the fiscal multiplier, and you get to cover your poorest citizens. And yet a number of states have turned it down out of political spite. So that's still going on. Whoops. Oh my goodness. That's not what I want to do. I want to do this. Okay. So now where do we stand? Oh, well, actually, and there's one other thing going on before I get to that chart. There's one other wild card here, which is there's now a Supreme Court case about repealing the ACA. This case, there is no word to describe it besides ludicrous. Now, I'm of course biased, but I'm not saying that myself. I'm talking about terms used by lawyers who brought previous cases against the ACA, call this ludicrous. Basically, to summarize, the notion of the case is the following. The individual mandate was challenged as unconstitutional. It was found to be constitutional because it was found to be a tax. The tax is now gone. So they didn't actually repeal the individual mandate. What it is, they set the tax to zero. So now I have a situation of a mandate with no tax. So technically it now is unconstitutional, which is sort of a silly distinction, but I guess it's true. So people are claiming as a result, the whole law has to go away, which is just a violation of any sensible notion of severability in a silly case. But we have a silly Supreme Court now. So basically, the silly case could actually lead to the entire ACA being repealed, despite the fact that literally there's no one in the world who on objective grounds will say this case makes any sense. So where does this leave us? Well, this leaves us with a three-dimensional chess game. Okay, here's our three-dimensional chess game. There are 8 possible outcomes. Okay, the first column is, does the ACA survivor get killed by the court? The second column is who wins for president, and the third column is who controls the Senate. So, for example, if the case survives the court, Trump wins and the Republicans hold the Senate, then we'll just see basically continued weakening of the ACA. The ACA will continue to kind of go along, still be effective, but ever less effective over time. If the case survives the court, Trump wins, but Democrats take the Senate, literally nothing's going to happen. Zero. If it survives the course, Biden wins, but Republicans take the Senate, then we could see some regulatory improvements, but no major overhauls. If, however, there's the best Democratic outcome, it survives the court, Biden wins, and Democrats take the Senate, then we could see a fundamental overhaul of the ACA, or what Biden last night called Biden care. And we will come back to that in the next slide. However, if the Supreme Court violates all norms of judicial law and actually kills the ACA, and Trump wins, and the Republicans hold the Senate, the ACA is gone. That's it. It's done. There's no replace. It's over. Okay? Even if they kill it and Democrats get the Senate, it's still gone. Okay? So basically, because they won't have enough to override a presidential veto, the ACA is gone. So now if Biden wins the presidency and they kill it, and Republicans control the Senate, the ACA is largely gone, but Biden might be able to replace some of the pieces through regulatory actions. The interesting case is if they kill it, but the Democrats sweep, there's actually a pretty easy technical fix. which is you just say, okay, we'll get rid of the mandate and the case goes away. Or you impose a $1 mandate penalty and the case goes away. So it's pretty easy fixes. So if there's a Democratic sweep, the court decision doesn't really matter. The court decision only matters if there's not, but the court decision is fundamental if there's not a Democratic sweep. So that's our three-dimensional chess game we're playing over the next couple of weeks. Now, what would JRB do? What would Joseph R. Biden do if he wins, if he could actually win and Democrats control the Senate? So this is now, I'm back up on row 4 here, the overhaul row. Well, what did he promise? He promised that the ACA, the percent of income that people pay for their ACA premiums would be capped. So let me just, bit of background. The way the exchange works now is you pay a percent of income that rises with income. So if you are at 139% of the poverty line, you pay like 3% of your income. It rises up to about 10% of income by 400% of the poverty line, which is about close to median income in the US. And then beyond that, you're unsubsidized. Biden would say instead of rising to 10%, it's going to rise to 8.5% and apply to everyone. No one in America in exchange will have to pay, who goes in the exchange will have to pay more than 8.5% of their income for insurance. Second of all, this current system puts you in what's called a silver plan. A silver plan is pretty minimal insurance. It's a plan with typically around a $4,000 or $5,000 deductible. Okay, it's basically a plan much less generous than typical employer insurance. Biden would say, no, we're going to default everyone to the gold plan, which is closer to typical employer insurance, more like a $3,000, $2,000, $2,500, $3,000 deductible plan. So he would cap what people have to pay and put them in more generous insurance. Third, he would introduce the public option, and I'm going to come back to that. That's a very important part. And then finally, he would extend the age of Medicare eligibility down from 65 to 60. Now, I want to talk about two pieces of this separately. Let's talk about the first two pieces because they're just money. Putting 8.5% of income and defaulting to gold are just money. Those are just, do you spend more money? But they have important implications. And to do this, I've sort of done what I like to do best, which is build a little simulation model. So here's a little simulation model I've built. And what it shows is, the table, each row shows what different income groups, shows different income groups. The columns show the percent of people in each income group who'd spend more than 10% of their income on healthcare, 15% of their income on healthcare, and 20% of their income on healthcare. What this comes from is a simulation where I add their premiums plus their expected out-of-pocket costs, given the cost-sharing structure of plans they're in. Okay, this is very much in the spirit of what John and Ben and I do in our work all the time. Okay, build this kind of simulation model. So what this says is basically, look, for people who are very poor, no matter what, they pay nothing. But if you look at current law, if you look at, say, someone who is 400 to 500% of the poverty line, let's take someone down here. Almost all of them pay more than 10% of their income. Why? Because they're not subsidized anymore and they have high cost sharing. Indeed, a third of people in this income range still pay more than 20% of their income for healthcare. That's a lot. Okay. You'll note there's a bit of a regressive element here, of course, because when you get very rich, you spend less because the costs are fixed and your income's going up. Now, what would Biden's proposal do? Biden's proposal would significantly cap these numbers. Okay, so here's pre-Biden. You note, if we focus, for example, in the last column, you note once you get above 200% of poverty, you have people spending, over 10% of people are spending more than 20% of their income. And it's a third of the people here. Note what happens with Biden. Those numbers go down dramatically. Virtually no one is spending more than 20% of their income on healthcare. But you still have one sort of glitch here, which is there's still a lot of people in this range who are spending a lot. And that's because even the gold plan is not that generous. So I've suggested to the Biden team a revised plan, which would cost a little bit more, but would offer more protection to the people in this range through basically not just defaulting the gold, but giving them more subsidies. Okay. Moreover, the other feature I don't like about the Biden plan is it continues to be regressive in that the richer people still spend under the Biden plan. Remember, you're capped at 8.5% of income for everyone. So if you're rich, you're really protected. I don't think that's fair. I think we should raise that to 12% of income, and that makes it a less regressive plan. So anyway, the bottom line is it's just cash. There's different numbers of how you could do it. The more interesting part is the public option of Medicare expansion. Now, public option, let's talk about what that means. Really, there's two versions of a public option. There's heavy and light. Okay, we have to distinguish them. The light public option is simply saying, alongside all the private plans in the exchanges, we will offer a government-sponsored nonprofit insurance plan, which basically looks like any other insurance. It's just called GovCare. Okay, that's good because there's evidence that Lee Moore, Daphne, and I have produced that there's a number of options go up on the exchange, premiums fall, but it's not game-changing. The heavy public option, which Jacob Hacker actually had in mind when he designed this, is to literally offer Medicare or as an option, which means to literally offer an option with regulated rates that providers are paid, which would be significantly cheaper. Okay, that's a big issue. There's other technical issues, like, for example, part of what Biden wants to do, and the most exciting part of his public option plan, which would be true either as heavy or light, is it's a way to get people in the non-expansion states like Texas and Florida enrolled in health insurance. Because you'd say, okay, fine, anyone who's poor can now get the public option. Okay, but that's hard to know how to do it because right now it's Medicaid's a state-run program, Medicare is a public program. There's a lot of, the bottom line is there's a lot of difficult issues in designing the public option. How do you coordinate it with the existing exchange options? The existing exchange options don't look like Medicare. So if you want to match the existing exchange options, the silver, gold, bronze, you have to deviate from Medicare. But the whole public option idea is to give people Medicare. How do you resolve that tension? Are you just giving people Medicare for free, or are they buying in? Okay, if they're just buying in, why do you need to do this given the ACA? So basically, there's a lot of difficult, I'm going fast, but the bottom line I want to leave you with is a lot of difficult design issues of the public option. But then there's basically the fundamental political issue, which is, can you do it politically? Because unlike the previous options I talked about, which are just financial, and therefore you can do with only 50 votes in the Senate, when you do a regulatory change like this, you need 60 votes in the Senate. Okay, and so basically that will be impossible. There's no way the Democrats get 60 seats. I mean, unless it's just an insane blue shift. I don't know even if it's technically possible for the Democrats to get 60 seats, but they're not going to get 60 seats. Okay, so even if they control the Senate, unless they're willing to get rid of the filibuster, they can't do a public option because of technical rules. You can only do purely financial maneuvers with 50 votes. For non-financial change, you need 60 votes. So it's not clear the public option can actually happen. In Medicare expansion, same thing. Now, the question our European friends can ask is, why are we having this bullshit like around the margins discussion? Why not just go to single payer? Well, I unfortunately haven't been able to attend much of the meeting, so you may have covered this, but we have to remember in the American context, there are three reasons why single payer is fundamentally impossible. And once again, this is not about economics. Okay, this is purely politics. There's three fundamental barriers to single payer. The first is, currently we finance health insurance in America through a hidden tax, which is that employers provide health insurance and they pay for it by paying us less. MIT doesn't give me health insurance out of the goodness of its heart. It gives me health insurance and pays me less money. Okay, if we move to a single payer system, we replace that hidden tax with an explicit tax. That is not good politics. Okay, that's problem one. Problem two is there's 160 million Americans with employer-sponsored health insurance they're by and large satisfied with. They're not going to be very happy of giving that up for some unknown Bernie care. That's not going to happen. And finally, there's the biggest issue, which is we have a $1 trillion private health insurance industry in America. I'd like to think it's otherwise, but there is no way we're going to take on and win against a $1 trillion industry. We bail out industries that are a fifth that size all the time. The notion that we are going to say we're going to wipe out a $1 trillion industry is just silly. So single payer is not happening. The best, I think, if we think about the ambitious sort of Biden care plan, the Biden care plan up here, this is sort of the best I think we could hope for. This is good. This would bring millions and millions of Americans into health insurance, but we retain our multi-payer sort of inefficient system. Okay, but this is the easy part. Okay, this is coverage. Coverage is easy. That's just spending money. Cost control is hard, and cost control is worldwide. Cost control, now we talk about an issue that goes beyond the US and goes to talking about initiatives around the world. Now, most other countries have a main tool they use to control costs, which is they regulate prices. Most countries around the world regulate the prices. Indeed, I think the US is virtually the only developed country that doesn't fundamentally regulate the price in its healthcare sector. And this makes sense. Ever since Kenneth Arrow's article in 1963, we've known healthcare markets fail and we need to regulate prices. It makes sense. The US is the only one that doesn't do it. The problem is this isn't going to protect anywhere in the world against the coming tsunami of genetic treatments of rare disease. Okay? Price regulation in other nations is tied to value. So basically the difference in the US and the rest of the world is we pay a ton more than we need to for mediocre treatments. The rest of the world gets it right and pays less. But the problem is the new treatments that are coming along have virtually unbounded value. So paying by value will not solve this problem. So let's talk about SMA, spinal muscular atrophy. It's a horrible disease that kills kids by the time they're age 2 and they're miserable the whole time. It's awful. Okay? There is now a genetic cure for SMA. Literally, it's a miracle. They can replace your genes in a way which you are now cured and, in theory, live a productive life. Okay? What's that worth? Well, any sensible value of a life calculation would say $10 million, $8 to $10 million. So what happened was the company that produced it charged $2.1 million. And guess what? They get the same price in Europe that they do in the US. This isn't like Humira or other drugs where they're $200,000 in the US and $20,000 in Europe. Zolgensma for SMA is getting the same price all over the world, at least in developed countries. So suddenly the European model of regulating by value doesn't work anymore when the value exceeds, when the value is unbounded, it exceeds it. This is from a recent paper I've done with Andy Lowe and a graduate student, Irina Conti, and a graduate student. This is a simple projection of the number of expensive genetic treatments that we will see in the coming years, based simply on ones that are in phase 3 now, based simply on the ones that are in the pipeline. This is what's going to happen. We're going to be up to, within about 10 years, we're up to about 20 approvals. We're going to have 20 drugs. What does this mean for spending? Well, for cumulative patient treatments, what this means is that basically we are going to be treating about 1 million patients a year with expensive, this is our best, now this is the error band, this is a big error band, but we expect it could be as big as, it could be 1 million, could be as big as 1.5 million patients a year, could be getting expensive genetic treatments. What does this mean for spending? Well, in undiscounted sense, the upper bound is we could be spending something like $400 billion a year on genetic drugs. Okay, so this is a really, really big deal. 10 to 11. How did I rise at 400 or 40? This is cumulative. I'm sorry, cumulative. 400 cumulative cost. That's why it's so big. 400 billion cumulative cost over the next decade on genetic treatments. Now, these are all just projections, and this is a way lower bound because this is assuming no new drugs come along. This is the ones that developed. Let's think of another thought experiment. 10% of the US has a rare illness. Suppose that 10% of them get treated and it costs $1 million each. That's $3 trillion. Okay. And that's not just a US problem. Okay. This is a worldwide problem. So basically, the problem is we actually have to now think hard about how we value these drugs. The problem is that now I have a recent working paper that's about to come out with Rina Conti where we talk about all the problems of valuing qualities when it comes to rare drugs, especially pediatric drugs. How do you measure the constellation of rare physical consequences? How do you translate from parental valuation to child valuation? So we argue in that paper. Sorry?
Just take 1 minute.
Okay, yeah.
1 or 2 minutes.
So we argue in that paper is 3 initiatives are needed worldwide. First, we need to start now collecting the data needed to understand the value of life that's created by treating the genetic disease. If you look at, for example, the ICER report on SMA, on attemptable qualities in SMA, they did the best they could, but it's largely garbage because we don't know how to value a kid being able to be mobile versus not mobile, to hold their head up straight versus not hold up their head up straight. We need to now be collecting that data so that when these drugs are developed, we can have the valuations in place to know what these drugs are worth. We also need to invest in the science of evaluation. We need to move from pure RCTs to adaptive trials. It's hard to do pure RCTs when there's only 50 kids that have the disease or 100 kids that have disease. We need to move to adaptive trials. And then finally, we need more public release of information from drug trials, subject obviously to patient confidentiality concerns. And then finally, I think we need to think about a new model for paying for drugs. Should we think about, if the quality model is fundamentally unaffordable, do we need to think about a new model, which is more like a public utility model? Okay, cost plus reimbursement. Is that possible? It's incredibly hard. Measuring the cost of drug developments are incredibly hard. It's hard to figure out the profits necessary. But if we literally can't afford to spend $3 trillion more on new drugs, we need to figure out an alternative for how we're going to pay for them. So this is really an international issue that I think we all need to be focusing on. Anyway, thank you. I'll stop there.
Thanks, John. That was fantastic, and similar discourse to last night's debate. So clearly clarifying for everyone. But we have a bunch of questions, which we're clearly not going to get through all of them. But there's two themes. One, I think I'll start with the heart, which is the ACA, and a number of Gautam and Ben. There were a few questions around related issues with moving to gold and the public option, sort of how a more generous benefit functions. First off, basically, Gautam asked, how do you think of a public plan negotiating for prices with hospitals and providers? And you sort of hit that on the heavy side, but how do you think about that structure if it's something a little bit lighter?
I think basically, look, you can think about a distribution. On one distribution is the light option, which is literally there's no negotiation. It's just publicly labeled insurance. On the other distribution would be Medicare, which is about a 25 to increasingly, I think the typical hospital price is about twice Medicare at this point. So it's a lot less. And the question is where in there you end up. Now, my prediction is you can't go to the heavy option, because even if you got rid of the filibuster, because I think insurance companies will go to the mat and fight it. Insurance companies will win. Now, could you come with a public option where prices are regulated, but they're 150% of Medicare? Maybe. I don't know. The question is sort of what's the tipping point where insurance companies don't go to the mat and fight it? If you pay enough above Medicare, presumably if you paid 300% of Medicare, they'd love it. So the question is sort of at what point, does that fight happen? And I don't know the answer to that.
And Ben has a related question on this sort of actuarial value calculation. If we just have the demand side cost sharing as a sort of the only free variable for plan design, what about using narrow networks or vertically integrated plans as a way to get higher actuarial value without as much increased spending?
Well, actual value, of course, doesn't refer to the narrowness of the network. That's a purely financial calculation. But certainly narrow networks are a huge part. I think Obamacare has actually massively promoted the use of narrow networks. That's basically how plans compete within these levels, is through, if you look at the price variation on any state's exchange, the variation within a silver tier or bronze tier is enormous, and it's all about networks. So I think they're already using that a lot.
Yeah, John, let me just jump in to clarify. I know about kind of the heterogeneity in the networks. I guess my question was more, right now the default, so when we talk about where we're assigning people based on the subsidies, for example, is silver, and the Biden plan talks about gold. And I was kind of wondering, why is that in some sense the default dimension that we're thinking about? Why isn't it gold plus narrow network?
Because I think we still want to preserve choice. So within any branch, we want to let people have the choice of broader narrow networks. I'm sorry. No, here's a better answer to your question, Ben. It's tied to the second lowest cost gold. So it is tied to narrow networks. The subsidy is tied to right now it's tied to the second lowest cost silver. So we tied to the second lowest cost gold. So it really is sort of gold plus narrow network.
I see. Thank you.
Yep.
All right. Well, we'll leave the mics open for any conversation, but we should take our break before the next session. But John, we should all thank you very much. It was a phenomenal.
Yeah, I'm happy to hang around for a few minutes if folks have questions.
And particularly opening up this clearly international issue at the end, which I think is going to be unfolding in front of us over the next decades. So we're going to follow up here with managed competition, which I think does give a lot of insights potentially from international systems into what an ACA may look like under different versions. Line 4 there, and we'll be coming back. Let's take 10 minutes. So be back at 9:45 Pacific and whatever the equivalent is in your local time zone.
Yeah, John, I think the issue you brought up at the end with the high cost drugs, I think it's like absolutely fascinating, in part because it just has to have have us kind of almost like rethink the whole financing system for healthcare. And if GD in some sense, if kind of unconstrained, I would bet that the kind of proportion of GDP we're talking about for healthcare would almost like double or something like that.
Yeah, I mean, I think it wouldn't double, but my guess is this could end up amounting to realistically an increase of 25% in the amount of GDP, and that's just rare diseases. I mean, that's presumably going to come with a genetic cure for cancer or something. But basically, yeah, I think it's a fascinating topic, and I think it really realized I was giving a talk in Spain, and really the Spanish healthcare system I think is terrific. Got a lot to recommend it, and I was saying, but you guys, it's all good until this next tsunami comes. I mean, nobody, a quality-based system doesn't save money when there's a miraculous drug. And basically the question is, what are we going to do about that? And maybe the answer is, look, I mean, if I had a kid with a rare disease, I think we should be willing to increase healthcare spending by 25% to make sure my kid leaves. And maybe we just eat it. Maybe we just do, because these drugs are just incredibly valuable. But I do think we need to really step back and think a lot about alternative modes of valuing and pricing drugs. Partly just because, I sort of had avoided really thinking hard about the quality literature until the last couple of years when I started working on this. And it's a mess.
Yeah, and what's so interesting about that is in our discussion yesterday, and I think the discussion that's coming today, a lot of the discussion of the different international health systems does reflect, of course, this notion of solidarity. So kind of how much are people willing to kind of have this redistributive ethic? Right. And what's interesting about what you're talking about is that, as those kind of treatments become more and more possible, I think you're just hitting that tension, that specific ethic, just like more and more and more and more, because you're talking about a case where it's, 5% of people might need these treatments, but they're insanely expensive. So
and once again, the harder part is the ones that aren't life-saving. So, you take the Zolgensma is the second genetic treatment to be approved. The first one's Luxturna, which is for a genetic cause of blindness, which costs $825,000. Actually, I got to say, it's one of my most proud moments of my training my wife as an economist. She's not an economist, but I was talking about Luxturna, and I was saying the way they price is $425,000 an eye. And she said to me, why don't they just do one eye? The second eye is just for depth perception. We could save a lot of money, which I thought was a great economist. I was very proud of her. That was a great economist answer. But, these things are, when they're life-saving in some sense, look, I think society will be willing to bear it. But when it's, you look at drugs that come out, you look at Zydeco for cystic fibrosis, which is really about reducing side effects and is hundreds of thousands of dollars a year. That's where the solidarity is going to get tested.
Well, but isn't that where quality stuff will then still work pretty well for that, right?
Well, I mean, if qualities can be, that's my point. Is just, once again, I feel like, once again, thinking about the academic side of this. Okay, there was this huge burst in quality literature when I was a grad student, which I think at the time I wisely chose to ignore. And this is my first attempt to really understand the quality literature. I feel like there's not enough quality of economists working on quality. Okay, there's some very smart people who've done some really good work, but it's really a fringe of the profession, a fringe of the quality. There's a lot of people who are doing mediocre work, but in terms of the high quality economists, people on this call, there's incredibly little work. And I think that actually it may be time for some people in our profession to actually really think more seriously about this area, which I think folks like you guys and me have largely avoided because it seemed like a quagmire. But it's going to be a quagmire, which is going to be one we're going to have to address in the coming years.
John, do you view, there's always been this bit floating around, which is how much of what's called R&D that we pay, I don't know what Tufts tells us we pay now, but the 800 million when I was in grad school is actual R&D.
2 billion.
Yeah, so that's inflation. There you go. Or that's how old I am. But if a lot of these newer things are base innovation, this is CRISPR, which came from universities. And most of the money to bring it to market is related to the interaction with the regulatory system and distribution and marketing. It may not be, but do you think that might be different in the context of these newer drugs in which you might have other levers? You still have to have better measures regulatorily, but where we might look at it slightly differently than just, we've got one lever, it's patent life to get stuff to market. And we're
Well,
gonna pay a lot.
I mean, look, John, I since I wrote my book, Jumpstarting America, but I've been fascinated with this incredibly bizarre dichotomy of the way R&D is paid, which is we pay of 100% of basic R&D, the government does, then it wipes its hands and hands it off. It gets none of the money from it, and it's not involved at all beyond that, except for some regulation. That can't be optimal. It can't be optimal to have that cliff where we go from paying 100% of R&D cost to zero. And I think we need to rethink that whole model. And it's hard, but I think we need to, if you look at, for example, the job market paid by Tamara Ostrom this year from MIT, where she showed that basically drug companies cook the data, essentially cook the way they run their studies to actually make their drugs look better. She looked at drugs where they flip between the drug being sponsored in the trial and being controlled in the trial. And when the drug's being sponsored, it looks a lot more effective than what's the control, which is about how the trial's set up. We need to be thinking about more nationalization, quite frankly, of the trial process, but in return, the government sharing more of the returns to the drug benefits.
John, Rich Gilbert has a question, and unfortunately, I opened the mic up, but I don't know if, Rich, whether you can speak as a participant, but he asked, what about competition? Unfortunately, the Biologic Regulation Act makes that harder.
Yeah, no, I mean, obviously we should use competition to the extent we can. It's just not going to work for genetic treatments because basically the problem is you can't test whether, for a biologic treatment, you can't create a generic version without running trials. I mean, you can create a generic small molecule without trials. You can't create a biosimilar that's really equivalent without running some trials. The problem is who the hell is going to want to be a placebo in a trial? If your kid has got some rare disease who's going to die and there's a drug out there and they're like, well, we might have a new drug that might work. Why don't you take a placebo instead? You're like, you, I'm not going to be a placebo on that. But there's one that works. I'm going to keep my kid alive. So I just don't think that competition can work with these rare genetic treatments. I think once it's out there, you're done. So I think we need a regulatory solution. I think there's just no alternative than a regulatory solution. And I think what's really striking is you just look, this is the first drug we got introduced at this Zolgensma, this drug for SMA. It's the first one I introduced at the same price in the US and the UK. First one I don't know if Carol can verify or not, but I can't remember the last case of a drug being introduced, an expensive drug being introduced at the same price in the US and the UK before Zolgensma. Carol, do you, am I right?
That. Yeah, that's right. I mean, no, it hasn't been. I mean, in some ways, in reflection to your kind of point, John, I think in some ways, countries that have total global budgets and therefore single payers within those global budgets, or have a global budget and then get everyone with price regulation, have grappled with this a little bit at the margins.
Good point.
So, and have thought about it. I mean, you've been thinking about it in Spain. The UK has been thinking about it for some time, what you do about these very expensive products. I mean, not the genetic stuff, but these very expensive products. We've done it with cancer treatment all the way along. We didn't have Herceptin until 15 years ago. We didn't have Kyela, some of the other drugs, till 5 years ago. And the population has broadly accepted that because of kind of the workings of a global budget and NICE. And I think, and when we were talking about Taiwan yesterday, Taiwan's helped by the fact it's got a lot of IT and a lot of growth. So it can kind of buy off bits of its population in that sense and provide them with high healthcare. But I think those debates have gone further than they have gone for you guys. And of course, you do a lot of the innovation, but it's not, you don't do all the innovation in the drugs.
But how are they going to, Carol, if I can just ask, I don't want to delay too much, but this is really critical. How do you think these countries are going to deal with a series of drugs that cost $2 million a pop coming along? Are they literally not going to cover drugs that save kids' lives?
I think there's going to be a big debate, and because the numbers are small, because N is small, then there will be exceptions made and people will crowdfund and send them to the US. I mean, that's what's happened with some of the kids. So I think as long as N is small enough, now, of course, N is small for every drug, but as you showed, you might have a hell of a lot of drugs in there.
Yeah, I mean, the one for hemophilia is in phase 3. A lot
Yeah.
of hemophiliacs out there.
That's a lot of life. And the other thing I suppose you might think about is that actually research does stuff on picking up this for parents before they give birth to these kids with genetic disorders, in which case you might switch the cost to abortion, which is kind of a lot less.
Well, that's not controversial at all, Carol. That's fine.
Yeah, that'll sail through.
Yeah, that'll sail through. That's an easy one. We're talking about hard things here.
Anyway, I'm gonna say goodbye. It's Friday evening, and I've unfortunately got an engagement. But thanks, John, for a great show. Thanks, Ben and John, for inviting me yesterday. And I'm sorry I can't stay for the rest of today.
No, I understand.
Thank you so much, Carol. Understandable.
As we said yesterday, we really appreciate the sacrifices of the international crowd.
I really apologize to the managed competition guys for having to miss your talks too, because I would have loved to see them. I'm sorry I had a long-standing engagement for this evening.
Thank you, Carol.
Thank you. Enjoy. All right. Well, with that segue, let's move to the managed competition section of the conversation. And the countries we're going to focus on for that are first Germany. Sebastian Bauhoff from Harvard University is going to be speaking to us there, and then we'll have Johannes Spinnewin talking about the Netherlands. And Johannes is from LSE, and he is not Dutch, but Belgium is about as close as we could get. So we're looking forward to that conversation there. But we will, just a reminder, now that we're back into the more standard format, we will be doing both speakers and then collecting Q&A at the end of that. And I'll give you a 2-minute warning when you're speaking as well to both